what we are doing is opportunistic infections in critical care. It's quite a wide topic, really. At some point I didn't know where to start from. Why? Because there's a lot of overlap with HIV, and that had been done a few months back, and I did not want to really dwell on HIV and opportunistic infection. My aim was to just look at opportunistic infections in critical care, which involves all patients, including HIV infections in AIDS. So, as you know me, I'm Emily, one of the registrars in Leicester Royal Infirmary. I'm a specialty doctor in critical care. So we'll be looking at, it looks like it's short, but with what I've written, what we'll be looking at, it's quite wide, but I've tried to make it as simple as possible. So we'll do the introduction, overview of host defenses. The aim is to understand the deficiencies in the deficiencies in the immunity and the results of that. What I mean is that what infection you would get when a certain component of your immunity is deficient. Predisposing factors and looking at secondary immunodeficiency and related opportunistic infections. I did not want to go into all the details of primary immunodeficiencies. Those are not common in our ICU. So secondary immunodeficiencies are just mostly the acquired ones due to various reasons. So what is an opportunistic infection? It's a simple term as it is. It's when you have an infection with microorganisms. If you were immunocompetent or your immune system was had no issues, you would expect to fight some of these organisms. But when your immune system is compromised, you end up having microorganisms that would normally not cause infection, in that case would cause infection. And this could be from your normal flora, which end up multiplying and out of control, and you getting an infection. It could be that is from the microflora. It could be some endogenous primary pathogen. Maybe you have usual bacteria in the nose, in the pharynx, which end up causing infection. It could be something that you have acquired, just nosocomial pathogens, and these are usually sometimes will be just that they grow as you are in critical care, maybe because you've been on antibiotics, so they predominate and end up becoming an infection. Or it could be as a result of something that you've obtained that was not in your system from the beginning. So that's opportunistic infections. We'll be looking at the overview of the host defense. So if you remember that our immune system is, we have the physical barriers, what provides our immune system, our immune system is classified as, there's the physical barriers. The physical barriers here include the skin, the stomach acid, and mucociliary clearance. So we all know what that means. The mucus that is in your airways, in your gut, that will provide that kind of protection from infections, and then the cilia that will help cilia that helps clear it, or the peristalsis in the gut as well. Basically, then we have the innate immunity system. So that involves the monocytes, the macrophages, the neutrophils. All those have this phagocytic effect, microbicidal effect. We also have the natural killer cells, the complement system. So if you remember, the system that reacts to your infection fast is the innate immunity. They are quite rapid, occurs in minutes to hours, where when it detects an infection, there's that chemotatic activity where it moves to the area of the infection, and it's involved in now this killing of the infection, phagocytosis and bactericidal effect. So if you have an issue with that, then you'll get a certain kind of infection. What I mean is, if you'd find that some drugs would interfere with things like the chemotatic effect of phagocytosis, like corticosteroids, and these patients will end up with maybe mostly pyogenic bacterial infection. The adaptive immunity, which is the B and T lymphocytes, that is your cell-mediated immunity, your humoral immunity. And how I remember is when you have this kind of problems with the T lymphocyte immunity, if you remember that in HIV and in AIDS, you have CD4 T lymphocytes that are a problem. So if you meet a patient who might be having a T lymphocyte immune defect, think of all those diseases that you see in HIV infection. Makes it easy for you to know how to investigate the patients. Then the part of the adaptive is the B lymphocytes, where you have the your immunoglobulins that come up. So you'll be having things like IgA, IgG deficiencies, IgM deficiency, which I'm sure you've heard of the IgA deficiencies. And when you have that, then you'll probably have a patient struggling with suffering from things like pyogenic bacterial infections as well, or even complement as well, because they're mostly involved in this whole phagocytosis and opsonization. Now, so as I said, deficiencies, just a bit. So it is important to understand the different deficiencies in the immune system, because they determine the specific types of bacterial infection that a patient gets. Yeah. Critical illness and opportunistic infections. Why do our patients get the opportunistic infections? It could be because of all the, basically just being critically ill. You're having a major surgery or coming in with sepsis. You have a patient will be immunocompromised due to that. This whole, I won't go into the whole physiology of the cytokine storms and all those inflammatory mediators that are produced. But with that, if you think about the physical barriers are compromised, why? Because we have the invasive lines, invasive tubes, which, like the endotracheal tube, means that the cilia don't work well, or we are sedating the patients, they can't cough as much. Then thinking of other things like patients coming in ischemia, and imagine ischemia is also in the gut, so you will have an ischemic gut. That barrier is interfered with, and there is translocation of bacteria. So all those will result in patient getting those infections. Nosocomial infections are 5 to 10 times higher in ICU compared to patients in the wards. Other reasons for opportunistic infections in our patients is because they have an underlying disease like diabetes. Is already compromises your system in many other ways, which we'll discuss. And maybe the patients who have, now we are receiving a lot of hematology patients, hemato-oncology patients, patients who've had chemotherapy, autoimmune diseases, patients on different kinds of drugs, steroids as well, immune modulators. All those results in opportunistic infections. And as we've seen in LRI, we receive loads of these patients, especially recently. So what do I mean by secondary immunodeficiencies? They are as a result of an underlying illness, as I had mentioned, like diabetes, malignancies, protein-losing enteropathy, asplenia, HIV. They can also be as a result of treatment. And the treatment here, we're talking about things like solid organ transplant, hematopoietic cell transplant, chemotherapy, steroids, biologic immune response modulators. All this result in secondary immunodeficiencies that lead to opportunistic infection. So what I'll do, I'll look at the secondary immunodeficiency, the treatment-related opportunistic infections. This is quite a busy slide, but it's just an idea of what the different drugs do and what infections that the patient might get, and what you need to think of when you're trying to investigate a patient who presents to you who has been on these kinds of treatments. For example, corticosteroid, as I said, it will affect chemotactic activity. Chemotactic activity is that movement of things like neutrophils and macrophage to the area of infection in order to execute its effect. That is phagocytosis, bactericidal effect. So corticosteroid affects all this, plus it also affects the phagocytic effect and macrobicidal effect, and it will affect T cell function in a dose-dependent manner. And that's why when you have patient on a high steroid, start thinking that they could be having T cell deficiency, and they can get all those kind of infections, as I said, in patients with T cell deficiency, like in HIV. So when patients with corticosteroids, you expect things like Candida, which we know very well is quite common. Our usual concern is the bacterial infection when we are pulsing patients. So the bacterial infection gram-negative and gram-positive, herpes virus. Think of reactivation of TB in these patients, especially when you can't even find any other cause and they're just unwell. Then we have the chemotherapy drugs like cytotoxic cyclophosphomides. All these mostly have an effect on the bone marrow, which we all know, and the patient will come with neutropenia, lymphopenia. They have this, they suppress T cell function, but B cell function. And with that, you need to investigate all kinds of opportunistic infections, as I say, that are associated with T cell. That's how I remember it. And we have, I will not dwell on the others. So we have, as you can see, patients on azathioprine could even get the JC virus with progressive multifocal leukoencephalopathy. I've not seen it in any patients who have this, who have been on these medications. Maybe in HIV, which is quite common, especially in very low count. But clearly, we need to be thinking of such things when a patient comes with some neurological deficiencies or illnesses. Start thinking of things like this. CMV, which is quite common in most of these immunocompetent patients. Fungal infections like Candida and Aspergillus as well. We've been receiving a lot of patients who've been on immune modulating response drugs like infliximab. As you've seen, it's being used in patients who have inflammatory bowel disease. These patients also, the same issue of macrophages and monocyte phagocytosis is impaired. And you need to, when you have a patient coming with on this medication, start thinking of things like if it's bacterial infection, TB, depending on what they present with, TB, listeria, gram-positive, gram-negative, atypical bacteria, hepatitis B and C, and fungal infection. And that's why you see us doing galactomannan and beta-D-glucan for these patients who come in with, who have been on this medication. Not forgetting patients who come in with methotrexate as well, who've been on methotrexate. They also end up with significant bone marrow suppression, and T lymphocytes as well are affected. And enough of these patients, you'll find that they're also on corticosteroids, meaning that their whole immune function, from the physical barrier to the innate immunity to the adaptive immunity, it's all affected. And in that case, these patients who are on this medication start thinking of all kinds of opportunistic infections that you can investigate on. Just a brief on what you would find in a patient who's had hematopoietic cell transplantation. That is just a summary of all the things that you will get from the time, when we mean pre-engraftment, that is from the time of transfusion to 30 days. And then from 30 days to 100, then more than 100, that is post-engraftment, and the lowest post-engraftment. These are the things these are all the infections they get. When I'm investigating some of these patients, and you're thinking of an opportunistic infection, the best way is to think of it as what is a possible viral infection, bacterial or fungal or parasitic infection. We tend to miss a lot the parasitic infection, that we don't see it a lot, but we need to remember that we have now a diverse population, especially in Leicester, and you will tend to see all kinds of opportunistic infections that come from a different kind of epidemiology, because they're coming from different epidemiological areas. You will probably meet patients with these kinds of infections. So start thinking of that. So things like Toxoplasma gondii, which is not common, but if you have someone who has maybe HIV/AIDS, has been coming from a different place, start thinking of such things as well. Yeah. This is after a solid organ transplant, same kind of infection really that you will come across in such in patients with T lymphocyte, because solid organ transplantation, what happens is that they are trying to suppress your T cell immune system so as to prevent organ rejection. And so, as again I said, start thinking of all the infections that can result from the T cell deficiencies. Yeah. Okay. I think I've spoken about this, the disease-associated immunodeficiencies. Patients who come with diabetes, I had already mentioned, usually impaired neutrophils. Patients who come with hematological malignancies, we know what kind of immunodeficiency they have. It could be T lymphocyte deficiency or B cell depletion in myeloma. And one thing I thought I needed to mention is that now, COVID-19, there have been cases where patients have been reported to have had aspergillus, candida, cryptococcus, pneumocystis, CMV, HSV. This is something I didn't know, that actually we've had patients who have actually had things like cryptococcus in COVID-19. So yeah. Something to think about when you're investigating. As I said, this is a long topic. I thought I should mention a few of the opportunistic infections and how to investigate, diagnose, and treat. Bacterial opportunistic infections, as I said, the gram-positive is actually the commonest. There's a gram-negative opportunistic infections. It's becoming less common, especially in the patients who have hematological malignancies. This is because now prophylaxis and prophylactic antibiotic is being given as well. So we'll speak about. I'll speak briefly about TB. As you know, we've had a couple of cases now with TB, which has been quite a good learning experience, clinical experience. So TB is, we have the Mycobacterium species that we have patients who come in with either TB lung, TB brain, basically disseminated TB, like one that we have recently come across. You will find the patient, if it's TB lung, the commonest is that they have that kind of shadowing or consolidations in the apical areas. They might have some fibrotic changes in the apices for patients who had previous TB and now maybe reactivated. You'll find some of them have this mediastinal lymphadenopathy, which can be a clue that with the clinical presentation that this patient might be having TB. Then in the patients who are severely immunocompromised, you'll find a miliary pattern, which is what we call millet seed when you look at the X-ray. When you start seeing a miliary pattern, starting the miliary TB, what miliary TB means is that there's been spread through the blood of the tuberculous bacilli, which now seed in different organs, and now you get this miliary pattern, which you see in the lungs. Then there's a TB meningitis, which can present as a just meningoencephalitis with inflammation of the meninges, or it can be a tuberculoma. So they come with this kind of motor deficits, or they could have hydrocephalus. The investigation usually is the SZN stain, where we do the acid-fast bacilli, or you can do the culture or PCR for mycobacterium. One of them is the expert gene, as you've heard. For those patients who come in with miliary TB, think of doing urinary TB tests as well. Yeah. Then for that patient who come in with a CNS infection, CSF, you'll do the ZN stain, the cultures as well. And patient would have lymphocytosis, low glucose, high protein, usually quite high protein. Yeah. So how do you treat it? I usually say the RHZ, rifampicin, isoniazid, pyrazinamide. Depending on sensitivity or resistance of this bacteria, we add other things. Ethambutol is one of them. So there's usually the intensive phase, where you use all the 4 drugs for at least 2 months, then continue with a maintenance phase of 4 months. And usually you will find rifampicin and isoniazid is the one that is used. However, there are cases where you would want to use IV, this other IV antibiotics, and this is in the case where a patient has decompensated liver disease. Remember that rifampicin and isoniazid can be quite hepatotoxic. So for patients with the decompensated liver disease, the fluoroquinolones like levofloxacin and moxifloxacin are used, aminoglycoside like streptomycin. And if they're not absorbing, it's only rifampicin and isoniazid that is in the IV formulation, so you need to add other IV formulation drugs. Steroid is also used in the case of meningitis and pericardial effusion. Yeah. So that's a picture of a patient with miliary. You can see the millet seed-like picture, and now the tuberculoma. Yeah. The fungal opportunistic infection, we have pneumocystis, Girovicia pneumonia. It used to be pneumocystis carinii pneumonia. And 20% of patients who come in acute respiratory failure in HIV it's PJP. Presentation, usually they come with this worsening cough, worsening dyspnea, the cough is dry, they have a high fever, but for some weeks. However, unlike bacterial infection, they have no hemodynamic instability. And if your patient presents with some hemodynamic instability, start thinking of, could this be something else, or could there be just a superseding bacterial infection, and you need to add that. Yeah. The other thing is, you need to remember is that these patients are at high risk of pneumonia, and I think we have recently experienced that with one of our patients. If the patient starts deteriorating or the patient is not improving, start thinking, could they be having pneumonia, pneumothorax, especially in those with severe infection. How do you diagnose it? It's a BAL is the best way of getting this a diagnosis. The BAL is the best sample for immunofluorescence, sustaining, or by PCR. Yeah. The radiological features in PJP, initially the chest X-ray might look normal. Eventually you start seeing this bilateral alveolar consolidation, just widespread ground glass opacification that spares the peripheral zones. At treatment would usually be cotrimoxazole. It's the first line of treatment. However, there's a patient who will come in with sulfur allergy, so trimethoprim and dapsone can be used in such cases. As a second line, primaquine, clindamycin, and atovaquone are a second line treatment. Any patients who has severe, which for us, by the time they come in ICU, it's severe PCP, PO2 is less than 9, or SPO2 less than 92, they need steroids. So adjunct steroids, and that's usually prednisolone twice a day, 40 milligrams. So most of our patients should be on that. ECMO has been done on I don't know what the outcomes are. Maybe the ECMO specialist will tell us, but there's no reason not to refer your patient who has PJP to the ECMO team. Candida. So it's the other fungal infection is Candida, which most of the patients in our ICU, 50% would be having Candida albicans. The presentation, what do we mean by disseminated? First, what do we mean by disseminated fungal infection? When we say disseminated fungal infection, it's either it's Candida grown in blood, that is fungemia, or it's a deep-seated infection as a result of hematogenous spread. Yeah. So when you have a patient who's not responding to antibiotics, has this persistent fever, and the microbiology results, you're not culturing anything, start thinking in terms of Candida, especially for the patients who are high risk, the patients who are on corticosteroids, diabetic patients, start thinking of Candida. There's high-grade funguria. If the patient is having candiduria and they're not catheterized and it's quite high-grade and they are high risk, start thinking of treating this patient, even if they're not, even if they are asymptomatic, or the catheter has been removed or changed, but the funguria is still persistent, or you have a culture from more than 2 sites, confirmed visceral fungal infection as well. Yeah. However, I will say the diagnosis usually is if you've had a patient who's had a blood culture that is positive for Candida, then you should not think of it as a contaminant. It's likely to be candidemia that patient has. The other way you diagnose is doing cultures of all the other fluids which you suspect, like acidic fluid, you have the CSF, tissue biopsies that have been done, or those burn wounds. If you see your patient has endophthalmitis as well, start thinking that there's a likelihood that this patient then has Candida and needs treatment. How do you investigate this patient? As I said, I think that I have said, but don't forget to do a retina exam for the patient. Don't forget to do an echo for the patient as well. Yeah. Treatment. In candidemia, what we do, you need to change the line. As long as you have grown something from that line, you need to change the line, especially if it's Candida parapsilosis, which forms biofilms. There is no two way about it. That line needs to come out and replaced if need be. If it's a patient who has a difficult access, if you have grown Candida from blood, from the catheter, you need to change the line, send it for tips. If it's someone who has a difficult access, you can rewire it, but once you rewire it and send the old line for culture, and the culture comes back with the same Candida, then that line needs to be removed, or else the patient will never get better. Yeah. Aspergillosis, the commonest is the fumigators, and the commonest that we see in ICU would be the lung, which we've seen a lot in the ECMO patients with the flu positive patients. Mostly they'd come with fever, cough, dyspnea, pleuritic chest pain, hemoptysis. For us, we don't see that. Maybe they get the aspergillus while they are in the unit, and you will see this whole fever and probably radiological finding like what you're seeing here of a fungal ball. Yeah. The PCR investigations is a PCR, galactomannan in BAL and blood. So basically, how do you treat all these invasive Candida? For the albicans Candida, they're usually sensitive to fluconazole, amphotericin, or echinocandin. Echinocandin are things like caspofungin. However, you need to remember that non-albicans candida, there are enough of them that are resistant to fluconazole. You need to use things like vori, amphotericin, and the echinocandin. As for aspergillosis, voriconazole, itraconazole, and amphotericin B is what is used. So looking at the cryptococcus, usually we see a lot it in the HIV, but you can see in all these patients who have hematologic malignancies, in the patients who have had solid organ transplant, and all that chemotherapy drugs. Usually it's a fungal infection that slowly creeps, indolent, progressive over some weeks, where a patient would be having this headache, seizure, could have visual symptoms and cognitive deficit. But one thing I always remember about the Cryptococcus meningitis is the headache. The headache could be very, very severe with the visual abnormalities. Mostly you'll find that they have on the MRI hydrocephalus. Usually they have high ICPs from the hydrocephalus. And other things you will see, like these things that looks like gelatinous cysts as a result of dilated perivascular spaces, which then coalesce to form this kind of gelatinous cysts. If you ever see this in a patient, you'll never forget. The CSF in this patient will show a lymphocytosis with a moderate protein increase, and glucose concentration is normal. How do you invest other blood tests, other tests that you can do? CSF, in CSF, you do an Indian ink stain. You can even grow yeast cultures, you'll see yeast as well, or you could have this cryptococcal antigen test, which what we call CRAG. You can do the CRAG, which you can also do in blood for patients who you can't do a lumbar puncture. The treatment, usually you'll find that these patients sometimes will require regular lumbar puncture, and that is the most satisfying lumbar puncture you will have, because the headache just settles and the patient is more settled. It's quite satisfying. Treatment, ambisome and flucytosine for at least 8 weeks. Yeah. If there's a challenge with ICPs, think of involving the neurosurgical team. Parasitic infections, as I said, toxoplasmosis. This, as you can see, it's usually they could be multifocal, more than one, but in this case, I'm showing one patient who looks like they have one space occupying lesion, can sometimes be confused with a tuberculoma or a lymphoma. The presentation usually will be motor deficit and altered cognition and seizures. As I said, that will be the MRI presentation of this kind of ring enhancing lesions in the cortex and basal ganglia, which can be even multiple. Yeah. CSF PCR Forti-Gondi is a mode of diagnosis. Also, if you have a patient who has HIV with this kind of MRI with a very low CD4 count, start thinking of that, and not just tuberculoma or lymphoma. Treatment is pyrimethamine with sulfadiazine for up to 6 weeks with regular clinical and radiological review to monitor treatment response. So you expect that in 2 weeks the patient should have shown progress. And if in those 2 weeks patient is not showing progress at all, then start thinking of things like TB, or could it be cerebral lymphoma. Cryptosporidiosis usually is a parasitic infection. In the immune competent patients, it is self-limiting, might last for 2 weeks. But for those patients who are immunocompetent, it can go for more than 2 to 4 weeks. Sometimes it can be even prolonged for months. It can be quite a debilitating disease. Diagnosis is through oocysts or DNA in stool, antigen tests as well, and the treatment is nitazoxanide. However, there are other drugs that are coming up for use. Viral opportunistic infections, nothing really much to say about them. It's quite a wide topic as well. The commonest one that we know is a CMV. CMV is multisystemic, causes multisystem involvement. It can cause retinitis, colitis, and esophageal ulceration. It causes respiratory and neuro issues. Investigations here will be a PCR, CMV PCR, which I think we all know, which we've all, which I believe we all know, and the biopsy evidence, which can be also diagnostic. The treatment for CMV is IV ganciclovir or oral ganciclovir, or even both. When we see CMV, start thinking HIV must be very low CD4 count as well. The other viruses we have are EBV. EBV, the usual concern is EBV associated lymphoma, especially in HIV, HHV6, herpes simplex virus, and I think, if I'm not wrong, the HHV8, which is associated with Kaposi sarcoma. And that is mostly it of a summary. I know it was quite a lot of information, trying not to overlap and trying to have a picture of what to expect for our patients who come in with some form of immuno incompetence. But anyway, I hope it was a bit helpful as a summary. Any questions? Yes, Jenny.
Not a question, really, rather a comment.
Yeah.
COVID, there's been quite a few cases of CMV and Epstein-Barr virus reactivation.
Yeah.
Similarly, case reports of TB reactivation following COVID as well. And also flu and COVID both increased the risk of invasive group A strep infection for a number of weeks or months after. So sometimes you'll see sort of a spike in viral illnesses, and then a little while later we'll sort of have a flurry of group A strep cases. Yeah. And there may well be a link between those, and that's stuff that was published back in sort of 2016, 17. Yeah. There's been a few quite high-profile cases of aspergillus, including one of the Scottish MPs who unfortunately was in hospital and caught aspergillus whilst he was in. So this stuff gets public attention, it gets media attention. And as Emily said, you know, we put a lot of lines and tubes in patients and render them at very high risk of infection. So that's why we keep banging on about hand hygiene and making sure that we're following best practice when we're inserting lines and tubes, because our patients are so vulnerable.
Yeah. I mean, I didn't know much about COVID-19 until when I had to present this. I didn't know there are some things that actually our patients come in with, and I think it gives you an idea now of what you need to start investigating when your patient is not getting better, because if actually they're even getting PJP, I think these are the things we should all be looking out for: the CMV, as you say, the TB. Yeah.